Okay, COPD. So we already have a pulmonary video that talked about respiratory acidosis in the setting of COPD, but today we'll talk more about the pathophysiology and other complications of COPD. Of note, people with symptomatic hypercapnia, this really requires high clinical suspicion, and it can easily occur in patients without any significant hypoxemia. Now remember, in COPD patients, they retain CO2, and they have very shallow breathing, and they have very high levels of ventilation-perfusion mismatch, which can lead to respiratory failure. A lot of these clinical manifestations of hypercapnia are neurologic. Moderate hypercapnia can often lead to headaches, or they're incredibly tired all the time, but it can cause delirium, coma, or even seizures. So remember, you have to have high clinical suspicion. In 90% of the cases, a lot of these patients get COPD because of tobacco use. Smoking is the biggest risk factor for COPD, but if you quit for more than 10 years, you're not at increased risk. Remember this for step 2. Patients who have had a history of secondhand smoke have an increased risk of COPD by a lot. Even patients with close proximity to smokers, whether or not it's secondhand smoke, they have a very high risk of COPD as well. The pathophysiology starts with asthma, and then this can progress to COPD. COPD is classified with the GOLD classification, and this is based off post-bronchodilator FEV1 percentage. Mild COPD will have an FEV1 of 80% or more. Moderate would be 50 to 79%. Severe would be 30 to 49%, and if your FEV is less than 30, you have very severe COPD. The pathophysiology for COPD is because of chronic airway inflammation. This is a result of significant exposure to noxious stimuli, and what you have is increased oxidative stress. Most commonly, of course, is tobacco smoke, and what you have is increased reactive oxygen species by inflammatory cells. Eventually, you have smooth cell hyperplasia of the small airways, and because you're hypoxic, the pulmonary vasculature also undergoes hyperplasia, and you have pulmonary hypertension, which can actually eventually lead to a heart problem called cor pulmonale, which is a heart condition where you have impaired function of your right ventricle. Bronchodilators are the mainstay pharmacological treatment for COPD, and sometimes inhaled corticosteroids are used like budesonide. If your PaO2 is less than 55, or if your SaO2 is less than 88% at rest, then you have to have long-term oxygen therapy. This is very high yield because STEP likes to know what increases survival in patients, and long-term oxygen therapy increases survival in patients with COPD.